Chapter 40, Nursing Care of the Child with Alteration in Gas Exchange Respiratory Disorder. In this chapter, we're going to talk a little bit about the anatomy and physiology differences in kids and adults. We're going to talk about some of the respiratory illnesses that we see in children. We're going to talk about a few of the lab tests, maybe not too many of those. We're going to talk about a couple of the medications. We're going to talk a little bit about risk factors with some respiratory disorders. We're going to talk about some of the signs and symptoms, nursing interventions, and then family impact. Excuse me. So alterations in gas exchange, which are respiratory disorders, are really the most common pediatric illness, is what we see when kids come in the hospital, into clinics, being admitted to the hospital. The research shows that children who are in families with lower socioeconomic status will have a higher risk of the severity or the number of respiratory illnesses. I talked a little bit about this before, is that kids can decompensate very quickly. And children with chronic disorders, say if they have cystic fibrosis, diabetes, some congenital heart problems, sickle cell, they are often more at risk and have a higher rate of mortality and morbidity. Time of the year. So we're coming upon flu season. So wintertime, we see more of the respiratory disorders. We see the kids who have asthma, the kids who have cystic fibrosis often have exacerbations during this time period. Some of the differences between kids and adults' airway is that the age is a little bit different wherever you read it, but they're nose breathers for about 4 to 6, which means that they can't breathe through their mouth if their nose is plugged. They don't produce a lot of mucus as a newborn, and so that they're more susceptible to infection. So any mucus they get could cause problems. They have a shorter neck, smaller, narrow airways, so congestion gets in there, they can have more problems. Their tongue is very much larger in proportion, and that can obstruct the airway if there's any swelling, such as an anaphylaxis or in an unconscious child. Their trachea is more pliable, so it's more likely to spasm. In the adult, they have a lot of tissues, sometimes tonsil and adenoid tissues, that can cause airway obstruction. Some of the things that we worry about with kids is increased work of breathing. We'll talk about that in a later slide. Their larynx is funnel shaped, so there's more of a chance of aspiration of foreign material or objects. And also because of the weakness of the the larynx, there's more of a chance of collapsing on itself. Congenital laryngomalacia, so that is a floppy airway, can be present at birth. You can have some other problems when that airway is floppy, and we'll talk about that in a later slide. So I think I went over this. They're nose breathers. We talked about their tongues are very large, and then that tonsillar tissue. So really any kind of infection that's going to cause some kind of inflammation and swelling is going to be worse the smaller they are because of that tissue. So the airway lumen is smaller, and there's a reduction in that size of airway, and especially if they have some kind of infection going on. And I talked about the congenital laryngomalacia. So you can see a normal voice box, so a normal larynx looks like this, and then breathing through a floppy one is noisy, and then this floppy airway is also more at risk for a collapse. So factors for respiratory illness, so smoke, environmental smoke, that secondhand smoke has an increased their kids are at increased risk for an infection. Also, if they have an underlying disease process like asthma, they can have bronchitis, pneumonia, things like that. Talked a little bit about breath sounds in a clinic in our skills day. Wheezing and rales we hear. Wheezing is one of the signs of asthma, and then that any kind of prolonged expiration could be some type of obstruction. So what we look at when we're looking at the child, we want to look at how are they breathing, their color. So color tells us a lot. So pallor is pale. Cyanosis is blueness. They can have circummoral cyanosis, which is around the mouth. They can be cyanotic. They can be acrocyanosis. When we think about that, we think about the acrocyanosis. We think about just the blueness to the hands and the feet. We see that more in the newborn. What is their rate of respirations? How are they breathing? Are they tachypnic? Are they breathing at all? Do you see chest rise and fall? So we're thinking a lot about that. We also are thinking about, is their nose clear? We want to suction that nose and get it clear. We want to make sure that we are listening to the lungs, both anterior and posteriorly. We want to see if we're hearing any noises like stridor, any wheezing, bronchi, things like that. Again, the respiratory airway effort. We want to look for any signs of increased work of breathing. And so retractions, we have another slide on that. Head bobbing, nasal flaring, we see those two in infants who are having air hunger. Anxiety and restless, when you can't breathe, you're going to be anxious and restless. We can see clubbing of the fingers, which is a result of chronic hypoxia. And then we want to check their their hydration status, because often when they are having some congestion, they're not eating, they're not drinking. And remember, we can check the fontanelles for dehydration. Otherwise, we have to use other ways to check for dehydration. One of the biggest ones is how many wet diapers have they had today? Are they crying with painful procedures? Do we see tears? Things like that. So we talked about retractions, increased work of breathing. Where are they having problems? You want to get those clothes off. You want to look at that chest. We always talk about upper airway and lower airway when we try to distinguish between disease processes, retractions that are going on. Retractions are pretty easy to remember. Your suprasternal are above the sternum. We can have intercostal, so between the ribs. Your substernal is below the sternum, and your subcostal are below on the lower part of the ribs. Depending on where they are can depend on the severity of the situation. They can also have the nasal flaring, head bobbing. We want to be able to identify the retractions and use the name. You can't just say the baby's retracting. We need to know exactly where they are. So learn these names of retractions, because you may see them later, and also because it's intelligent charting when we can talk about where the retractions are. So some common things that we see in kids, we see common cold. We see that in a lot of people. As far as the common cold is, we talk about it as an upper respiratory infection, so a URI, or you can say nasopharyngitis. It's caused by a lot of different viruses. Kids who go to daycare and those school-age kids are more at risk for it. It goes away 7 to 10 days. For kids, we don't want to give them a lot. We could give them Tylenol or ibuprofen if they're not feeling well. We're not going to give them any over-the-counter prepared cough medicines. We treat the symptoms. We give them, maybe some humidified air, lots of fluids to drink, maybe some Tylenol. but really they don't recommend any of those over-the-counter cough medicines for kids younger than 4. One of the biggest things that the HP 2020 has been talking about for years is reducing the number of antibiotics prescribed for the common cold. It's not going to help you, and it's just going to increase possibly resistance of antibiotics. So really gotten away from that over the last few years. So comfort, saline drops, cool mist humidifier, things like that. Basically, family education is no medications. And then things to look out for, bring them in for, would be a prolonged fever, or if they see some throat swelling. It lasts longer than 10 days. They have some other symptoms with it, like earache, headache. They're inconsolable, things like that. So pharyngitis is an inflammation of the throat. It is commonly just referred to as a sore throat, and usually caused by a virus. But if it is caused by a bacteria, we talk about tonsillitis. I'm going to go back to, let me go back. The pharyngitis, if we are suspecting strep throat, then we're going to do strep cultures and treat with antibiotics. The thing with strep throat and pharyngitis is a halitosis, so a really disgusting smell coming out of their mouth. Especially if it's strep, you can kind of identify that strep by the smell before you look for the exudate. Sinusitis, we do see this in adults and kids. Again, they have a very foul odor coming from their breath. They have that irritability and that pain in the sinus area. Basically, we treat the symptoms. Unless they feel it's bacterial, they will treat it with antibiotics. The flu, kids with the flu who are more at risk would be anybody who has a history of asthma or some kind of heart or lung disease. Those kids with diabetes, renal disease, if they're immune deficient, and then kids on chemotherapy are more at risk for severe complications from the flu. And also kids who have not had the flu vaccine are at risk for complications from the flu. Here's my slide on pharyngitis. I lost it. So viral pharyngitis is just a redness of the throat, irritated. You're going to go ahead and treat that symptomatically. It's self-limiting. If you see some white exudate, white spots, you're going to think more about strep. So we would do a culture, throat culture, and what we're doing is a rapid and then a culture swab also, 2 of them at the same time. Your book says that there's a low incidence of false negatives, but in my experience, we've had a lot of incidents of false negatives with the rapid, and that's why they culture it out and see if it's growing anything. It's usually staph or strep, excuse me, and they will call in a prescription for antibiotics at that point for the patient. They'll call them at home and notify them of the positive strep test. Sometimes you can see the exudate, and they'll go ahead and treat that, even with a false negative rapid test. Depends. So they look at the signs and symptoms also. You'll see redness of the pharynx, the tonsil exudate, and then a white strawberry tongue coating. So their tongue looks like a white strawberry. And there's a good picture in your book on that. Sometimes strep can progress to a peritonsillar or a retropharyngeal abscess. And so a peritonsil abscess would be swelling, and it shifts the uvula over a little bit, and they'll have some edema in the palate. And then a retropharyngeal is just getting worse, and it can cause complete airway obstruction. What they have to do with those peritonsillar abscesses, either the peritonsillar or the retropharyngeal ones, is they have to lance that. So they'll go ahead and put some numbing spray on that area, and they stick a large needle in there, and the stuff that comes out of there is very disgusting, and smelly, but that way it will shrink the area and the patient will not have airway compromise. And that's done right in the doctor's office or in the hospital. So tonsillitis. So we talked a little bit about sore throat, pharyngitis. If their tonsils are swollen and the throat's swollen, it's viral. If you see the swollen uvula, the white spots, the strawberry tongue, that's more bacterial. And we would treat that with antibiotics. Tonsillectomy. So tonsillectomies aren't done as much as they used to be years ago. So with tonsillitis, and for kids who get it frequently or have a lot of extra tissue in there, they'll remove the palatine tonsils. It's a easier procedure for kids than it is for adults. Kids will be kept in the hospital overnight. There's some danger signs for kids with tonsillitis. If they start bleeding, they could actually bleed to death. And I took care of a patient that happened to once. So one of the biggest things with tonsillitis is to remember that those are scabs when they take the tonsils off. So when they remove the tonsils, those are scabs there for up to 10 days. And so any food that is going to knock that scab off is going to cause bleeding. Happened to me with a patient. She was an adult, had her tonsils out, came into the small rural ER that I was working at in upstate New York, middle of the night, bleeding. They tried to cauterize it with a cautery. OR had to be called in. Specialists had to be called in. And by the time they got there, she died. She bled to death. So when you knock those scabs off, that can happen. So follow bright red blood. If they're swallowing constantly, they're swallowing the blood. If they're anxious and they just had their tonsils out, you might want to think about those signs and symptoms and get them back to a room or to the doctor right away. So always kind of lie them on their side after surgery. No coughing, no straws, no red foods or brown foods because you won't know if it's bleeding. And then sometimes ice. And then they'll give them analgesics with or without narcotics. In my experience, what we've seen is kids who have tonsillectomy, their throat hurts when they go home, and they give them liquid medication like Hycit, so it has some codeine in it, and they don't want to take it because it burns their throat, and then they end up coming in because they're severely dehydrated. So we end up giving them some IV fluids, get them to take the pain medication, and then they're okay. We talked a little bit about breath sounds in clinical. So your wheezing is a high pitched on expiration. However, in asthma, you can have inspiratory and expiratory, but typically it's expiratory with a prolonged expiration. And that can occur in the lower tracheal bronchioles. You can have crackles, and that's when the alveoli become fluid filled. So we hear that in pneumonia. And there's a little cartoon for you. So bronchi is more like snoring sounds, wheezing, and then crackles. So croup. So we see croup in kids, usually about 3 months to 3 years. And they call it a laryngeal tracheal bronchitis, and because it's inflammation and edema of the larynx, the trachea and the bronchi, and it's usually caused by a viral infection. Typically, it happens mostly at night. The kid might have a small viral infection. They go to bed, they're feeling okay, and then they wake up. Parents wake up to this croupy, seal-like barky sound. And so you can see that inside the trachea, it's swollen and it narrows the airway. So the kid is anxious, obviously. Sometimes if it was cold outside, not in Arizona, the parent would take them outside and that would relax that narrowing and they could breathe again. They take them back inside and they still have that croupy-like cough. If they're brought to the ER, one of the biggest things is you want to keep the kid quiet. You want to decrease their anxiety as much as you can. You want to not put an IV in them unless they are severely compromised or in respiratory distress. It is self-limiting, lasts about 3 to 5 days. Some kids are worse than others, and so they often will give them some steroids, just a single dose of steroids, which usually takes a while to work. So if they are still having symptoms, when they come in, they will give them racemic epinephrine, which is a aerosolized, so like a nebulizer, and then it has that effect of the vasoconstriction, which helps to reduce the edema. Typically, kids are admitted to the hospital after racemic epinephrine because they can have a rebound effect about 4 hours later, and you don't want to have them go home and get worse, so they will watch them for a while. On page 1487, there's a good chart comparing croup and epiglottitis. So we're going to talk about that. Next, so epiglottitis. So epiglottitis is an emergent situation. It's a swelling of your epiglottis. So it's usually caused by the Haemophilus influenza. So the Hib vaccine that has started in the 80s, they gave it to kids. We see a decrease in it. Kids who are not immunized or kids who are born at home often don't get that medication. So around 2 to 7, it could be life-threatening. They can go into a respiratory rest. What happens is there is a tightening in the throat area, and you can see the normal epiglottis in the picture on my left, and then on the right you can see a very, very narrow opening. The biggest thing with epiglottitis is the signs and symptoms are dysphagia, drooling, anxiety, irritability, and respiratory distress. So if you're suspecting epiglottitis at all, you're going to get the physician. You're not going to visualize the throat because they could have a spasm and their throat could close. Don't leave them alone. Leave them in the position that they're in. Do not lay them flat. You can give them some oxygen, but you want to do it in the least invasive. You don't want to scare them by putting a mask over their face. Maybe try to give them oxygen. And then if it's completely occluded, they'll have to perform a tracheostomy. Make sure you have emergency equipment at the bedside, so your code cart, you have suction, you have oxygen, and then the physician will take a look at that and see if it is epiglottitis. We'll then start them on antibiotics and something for the fever. They typically have high fevers. Bronchiolitis. So bronchiolitis is an inflammation of the bronchioles and the small bronchi. So we see it in the smaller children. Usually the respiratory syncytial virus is what causes it. The winter months, obviously, we're coming into those in probably October, November. We'll see more incidents of RSV. And then your book says that virtually all children will contract it. It just depends on some have worse symptoms than others. We really worry about the tiny infants because remember they have smaller airways. They are more at risk. They have larger tongues, things like that. And so the thing with RSV is it's highly contagious. Direct contact with respiratory secretions or from particles on objects. So I've read a few places that it lives on your uniform, on surfaces for up to 12 hours. So you really want to make sure that you're wearing all your PPE properly. We don't treat RSV with anything. It's a virus. And so supportive care, oxygen if they need it. We'll do a pharyngeal swab to make sure or to get results if it's RSV or not. But if you suspect it at all in the wintertime, typically they just isolate before they know. So sometimes they have a clear runny nose, sometimes a lot of snot. They manufacture a lot of snot. They can have a sore throat. They could have a little low-grade fever. With infants, typically they just are inconsolable. They have a lot of mucus and they don't want to eat. So then that's a concern for dehydration with them. So we'll do a pulse oximetry. It might be decreased a little bit. Chest X-ray. They're looking for some infiltration or atelectasis. I've never seen them do blood gases, but your book mentions it. And then the nasal pharyngeal. They say washings, but what we use is the nasal pharyngeal swab, similar to the COVID swab. And then your book talks about there is a vaccine for RSV. Your book doesn't talk about it. It's talked about in other books, but it's reserved for the kids who are very high risk. So your premature low birth weight kids. Otherwise, supportive treatment. It's self-limiting, and some kids can be sent home with it. Some have to be admitted. So there's just a little picture of how the airway looks with RSV. Asthma. So I talk a little bit about asthma too. I don't go into pneumonia or bronchitis or TB because we see all that in adults too. Same with epistaxis. Foreign body aspiration. I talked a little bit about that. Usually anything that's inhaled goes into the respiratory tract. And there's a lot of items that are choking hazards in kids, so we have to think about that. Sudden onset of the cough and wheeze could be a foreign body that they aspirated. Okay, sorry, back to asthma. So for asthma, it's an inflammatory airway disorder. So airway edema, some mucus production, not nearly as much as RSV. They could have complete airway obstruction, different types of asthma. So with asthma, we have a stepwise approach, so an asthma action plan. As the child's condition gets worse, we have increasing medications, and then we back off as they get better. Asthma action plans look like a stop sign. So depending on the colors, depending on the treatment, and then for red, there's signs of what they can do or call 911. You can see that a normal airway has a large opening. An asthmatic airway is going to have narrower opening, and when they're having exacerbation, it's going to get even smaller. And so they're going to be able to get air in, but when they're pushing air out, is sometimes it's going to be harder for them, and that's when you'll hear the wheezing. So you'll hear inspiratory wheezing, sometimes mostly expiratory wheezing, which expiratory wheezing is a classic sign of asthma. You may hear something called silent chest, and that's when you don't hear any air going in and out, and that's a very dangerous condition. Some kids can have exercise-induced asthma, so they really only have attacks when they're really being physical, and they use an inhaler for that. One of the 2020 HP 2020 goals is to reduce asthma deaths and hospitalizations and hospital emergency rooms for asthma. In normal times, when it's not winter, it's not respiratory season, kids take their regular medications, asthma should be able to be controlled. They shouldn't have to come to the hospital. Parents smoke, that irritates it. Non-compliance with medications for many reasons, sometimes cost. So we do see a lot of kids in the ER, typically with asthma. I remember I did my dissertation in an asthma protocol, and in the wintertime we could see in the pediatric ER just at Banner, we would see 200 kids a month with asthma exacerbations, some worse than others. Oops, let me go back to asthma. So with asthma, your goal is always to keep them out of the hospital, out of the doctor's office, things like that. And so avoiding those triggers. We treat them with short-acting bronchodilators. We treat them with steroids. We treat them with inhalers, which are short-acting bronchodilators. When you're using an inhaler for kids, you should always use a spacer. So a spacer goes over the inhaler, gives the child time to, when they squeeze the nebulizer for that medication, to slowly go into the spacer so they have time to take that deep breath. It's hard for them to coordinate. Take a deep breath, blow it out. Your next breath in, you're going to squeeze your inhaler and breathe it in all at the same time. So that's kind of hard for them to coordinate that. Let's see. Your book has a picture on page 1504 of an asthma action plan, and the doctor will write specifics in there of what medications to take, when to call the doctor, things like that. And there's some great pictures of a nebulizer and inhaler and a picture of a spacer, and it's on the bottom of page 1505. Talked a little bit about peak flow meters in skills. Peak flow meters are checking the oxygen capacity. They're really hard to use in the smaller kids because they can't seem to coordinate that type of mechanism. Cystic fibrosis. So cystic fibrosis is another disease that we see in the wintertime. We see more exacerbations. It's an autosomal recessive disorder, so affects a lot of kids. And so what is happening with them is they are have a dysfunction of their exocrine glands. So they don't conduct chloride and water transport, so they have really thick, sticky, tenacious sputum. It also affects the sweat glands, the GI tract, the pancreas, as well as the respiratory tract. And so those secretions, they have a hard time coughing them up and getting them out. Kids often are used to be a childhood disease. Now we're seeing kids live into young adults. I think survival into the late 30s is happening, sometimes with proper treatment, and sometimes kids have to have lung transplants. A lung transplant will buy them time. It won't cure the disease, obviously. DNA testing is being done, and screenings for cystic fibrosis should be done, especially if one child has it, the other child should be tested. As far as the pancreas, that enzyme activity is not working, and they have malabsorption of fats, proteins, and carbs. So they sometimes are of short stature. They have malodorous stools, so large stools. Obviously, the fluid affects their respiratory system. Staph or Pseudomonas could be the organisms. They develop nasal polyps. Boys have really thick seminal fluid, and so sometimes it blocks the vas deferens, and so making them infertile. And girls have thick cervical secretions that might limit the penetration of the sperm getting through. So reproduction is usually very decreased in this with kids with this disease process. You can't cure this. What we do is we test for it first. So we do a sweat chloride test. Sometimes parents would say their skin tastes salty. And then pulse oximetry, obviously, chest x-rays, they might have some thickening or some fluid, and then pulmonary function tests when they're feeling good. There's a little cystic fibrosis cartoon thing I put here. It's hard to read on Bongo, but you can read it in the slide, in the PowerPoints. One of the last things we're going to talk about is apnea. So apnea is the absence of breathing for longer than 20 seconds, or it could be shorter if it's accompanied by bradycardia. There's also what's called an ALTI or a BRUI. So an ALTI is an acute life-threatening event. The child stops breathing. They have some kind of color change. They become hypotonia, coughing, gagging. And this is on a kid with no medical problem. And then the newer diagnosis now they're talking about is BRUI, so brief resolved unexplained event. So some books just link ALTI and BRUI together. Some books want to separate it out. BRUI is usually less than a year old. There's usually no coughing or gagging. There can be absent breathing. They turn cyanotic, change in muscle tone. Sometimes there's an altered level of responsiveness. Sometimes it can be GERD, it can be meningitis, sepsis. Really, we're going to do a full workup. So you can call it either whatever you want. Somebody said that BRUI is the term they use on the boards. I don't know that for sure because I haven't taken them. But basically, if a parent comes in and says, you know, I was feeding my baby and she started choking and I had to start CPR or I had to do something to get her to breathe again, we're going to believe them. And so what will happen is they'll do a whole workup on this child to make sure there's nothing going on with them. We do what's called a septic workup because we're looking for sepsis. And they'll do blood cultures, lab work, urine, and they'll do a lumbar puncture. And so if anything comes back positive, of course, they'll treat that with antibiotics. If everything comes back negative, they may admit them for observation, maybe send them home on an apnea monitor, things like that. But they'll rule out all the bad stuff, make sure it's not anything bad. Apnea also is, we've seen in SIDS. So that is, SIDS is a sudden infant death syndrome in a child less than a year old. We've really reduced that incidence by putting kids on their back because remember they have no head control for a couple months, taking everything out of the crib, no unbundling. And then they said encourage a pacifier. I don't know the research behind that, but we have decreased the incidence of SIDS greatly. And that's it.